Greetings. We do have a few more people who are joining us, but the noon bell just rang here in my basement, so we'll go ahead and get started this morning. Welcome to Faith in the City. I'm Sylvia Oberly. I'm a member of the Faith in the City planning team. As you may know, Faith in the City is a series of monthly lunchtime meetings sponsored by Knollwood Baptist Church. It is now in its third year of highlighting issues in our community for deeper conversation. Though we have not been able to share lunch together since last spring, we are pleased to be able to still gather together and are glad you have joined us. Since our inception, we have focused on educational inequities to underscore the importance of ensuring equitable access, achievement, and outcomes for all students in Forsyth County and elsewhere in our state. We are grateful for many partners, some of whom are with us today, who join in this vision. We meet monthly, generally on the first Tuesday. And if you are not on our email list and would like to be, please let us know today by putting your information in the chat. We have also started a Facebook group called Faith in the City, KBC, where we can share information about other related events, post recordings of our meetings, and other relevant materials. Please visit our page and join our group. Today, we continue our year-long emphasis on learning from the crisis. How we can take the experiences and lessons from this time of pandemic and use them to create a more just and equitable educational system going forward. We have asked our speakers to bring us some very helpful and concrete medical information about our local COVID situation and how we can protect each other. And also what is being done within the schools themselves to bring students and staff back safely. We also want to address the questions of what can churches and other community groups do to assist these safety measures? And how can we continue long-term to support the healthy environments for those students who need it the most? With us today are Dr. David Priest from Novant Health and Daryl Walker, an assistant superintendent with the Winston-Salem Forsyth County Schools. We appreciate them sharing their time and expertise with us today. In just a few minutes, I will introduce them both. As they are speaking, please pose your questions using the chat function if you like, and Dean Clifford, another member of our planning team, will moderate the Q&A portion afterward. Dr. David Priest is Senior Vice President and Chief Safety, Quality, and Epidemiology Officer for Novant Health. He is a board-certified practicing infectious disease specialist and has been at Novant Health infectious disease specialist since 2008. During 2020, he has led the COVID-19 response for Novant Health and has been an advisor to local businesses, churches, school systems, and community groups. He has worked collaboratively with other experts to develop system-wide guidelines for the care of COVID-19 patients in both the hospital and ambulatory settings. Daryl Walker, Assistant Superintendent of Operations for the Winston-Salem Forsyth County Schools, is responsible for a variety of areas, including bond and long-range planning, construction, maintenance, transportation, child nutrition, warehouse, and distribution. He oversees the planning and implementation of steps to prepare our school buildings, buses, and other facilities for returning students and staff. He has been with the school system since 2007 after spending 20 years in similar positions in the private sector, including High Point University. Thank you both again for being with us today. We will begin with Dr. Priest, and at the conclusion of his presentation, we'll set aside a few minutes for the most immediate questions on his topic, but we also want to be sure to have adequate time for our second presentation. So Dean may move us along and we'll have additional Q&A time at the end of both topics. So mute your audio and welcome Dr. David Priest. Thank you.
Thank you, Sylvia. It's a real pleasure to be with you all today. Hopefully you can see my slides and let me know if there's any audio visual problems. I've done a lot of these talks, as you can imagine, and I'm always excited to talk to a new group who has a new perspective. What I'm going to talk about this morning, hopefully, or this afternoon now, in about 20 or 25 minutes, this is kind of what I'd like to get to. We're going to talk about the state of the COVID pandemic. We're going to talk about testing. We're going to talk about a little bit of our diversity and inclusion work, as well as public health work at Novant Health. We're going to talk about treatments and clinical trials, antibodies and vaccines. We're going to talk about the risk of acquiring COVID and how to protect yourself. We'll talk a little bit about children in schools, but I know Daryl is going to have a lot of information about that. so I won't dwell on that too long, and then kind of predicting the fall and winter. So that's kind of the plan here. That sounds like a lot to get through in 20 minutes, and maybe it is, but I think we can do it. So where are we in terms of the state of the pandemic? Those of you who have been living through the last 10 months know that this has been really unprecedented in the nation's history. This is one of the dashboards we use at Novant Health, one of many, and it's a couple of days old now, but we track very carefully the activity of COVID-19 across the world, across the United States, and certainly across the footprint of our healthcare system. Novant Health has 15 hospitals, 620 ambulatory sites. We extend from the Washington, D.C. suburbs all the way down into Georgia. Our biggest flagship hospitals are in Winston-Salem and Charlotte, and soon to be in Wilmington, as we're partnering now with New Hanover. So our data teams create some really nice data tools for us to track this really hour to hour to understand the burden of disease. So I can tell you we've had, and again, these are a couple of days old, but I try to update them as I very quickly, but we've had over 4,300 patients admitted to Novant Health facilities who've been able to go home after having COVID. Unfortunately, we've had approaching 500 deaths in our system. That's across, again, 15 hospitals. And we've tested now well over 300,000 people. We've believed from the beginning that testing was an important part of this. Unfortunately, we had the supplies to do that even very early on in the pandemic. You can see there are hospitals there, some of our hospitals there, and the current inpatient census there. I can tell you as of right now at Forsyth Medical Center here in Winston-Salem, we have 81 patients, which ties a new high for us at Forsyth Medical Center. So the hospitals are very, very busy. What we've seen over time, however, is early in the pandemic, patients tended to be older, often coming from skilled nursing facilities. The mortality rates were somewhat higher. As the pandemic's gone on, our hospitalized patients tend to be a bit younger. Our care teams have learned to care for patients more effectively. Mortality rates have gone down. People are less likely to need the ICU or have to be on a ventilator, but that certainly still occurs. And we still see outbreaks in skilled nursing facilities, both in the in North Carolina and across the United States, which can be devastating. And I like to put this into perspective. COVID-19 is now the fourth largest mass casualty event in the history of the nation, behind only the 1918 Spanish flu, the Civil War, and World War II. So now in the United States, approaching 250,000 deaths. So that gives us a little perspective as we think about the history of the Republic. We do track a number of other things as a healthcare system, and one of those is the percentage of tests that are positive in our footprint. You may hear about that a lot. And you can see over time, we have a rolling 7-day number. We do this on the county level as well, and I'll show you that in a minute. But I'll just point out to the upper right here, you can see the percentage of tests that are positive in our Winston-Salem market. So, Kernersville Kernersville Medical Center, Forsyth Medical Center, Clemens. You can see that number has trended up since late September to now a good deal over 10%. Now, those include anybody coming into the market from outside of in rural counties as well. It's not just Forsyth County. But the point I'll make here is we want the percentage of tests that are positive to be lower. The lower, the better. And we try to get those numbers down to about 5%. When the percentage of tests your community is doing is 5% or less, the public health teams have a much better chance of doing the appropriate contact investigations. In our market, we've been up over 10% or higher in recent weeks. And that often translates into downstream admissions to the hospital. So we see that trend going up, and we have some predictive models with that. We know that hospital admissions are coming, so we follow that very closely. There are a couple other things we follow very closely as well. And one is as an organization, we are entirely devoted to diversity and inclusion. We can have quality metrics, and we can look at those quality metrics and say, well, we're meeting that goal or we're meeting that metric, but we have to understand, are we meeting that metric for everyone? We may be meeting it in an overall way, but are we meeting it cutting across race and ethnicity and gender and zip code? And so we have dashboards that tell us how patients are doing with COVID, not just overall, but again, race, ethnicity, parts of our community that are underserved or historically underserved. Are we getting testing into those communities? So we take that very seriously. We have a very strong diversity and inclusion program at Novant led by Tanya Blackman, who's on our executive team. And we don't want it to be just a box we check. It's a thread that runs through everything we do. And it's not only the right thing to do, it's the right clinical thing to do. Providers and physicians need to understand if care is not equitable, and we need to work to make that care equitable. We also have public health partnerships that are very important to us, and we have data like this on the right. We track Forsyth County, we track the zip codes where there are more cases. We think about how to get resources in those communities and make sure those areas are served in an equitable way. It's very important to the care we provide at Novant. I did want to touch on treatments and clinical trials, because particularly this has died down a little bit, but we saw certainly in social media over the last few months, I was amazed at seeing arguments that people were having about hydroxychloroquine, a drug they may not have heard of 3 weeks before. There was debates about the dose. I was amazed by that. And it really spoke to, I think, sometimes the public's lack of knowledge about what constitutes an anecdote and what constitutes a clinical trial. So while we are not an academic organization, we do have a research arm. And so very quickly in the pandemic, we got our clinical trials up and going really aggressively. We had 7 clinical trials moving quickly to get the latest potential therapies into our providers' hands to give to patients. So remember, clinical trials have to be conducted and they have to be blinded to see, are these therapies worthwhile? It can't be one doctor saying, I used this drug on a few people and it works. We have to prove that in clinical trials. So we participate in that. Clinical trials are voluntary. Participants can withdraw at any time. We have to make sure there's a lot of ethics around those trials. But they are better than anecdotes, and they're not anecdotes. We need to prove these therapies work. And this is a time of a lot of medical misinformation. And so that really drives, even physicians fall into the trap of medical misinformation and using anecdotes and wanting to prescribe therapies that have not been proven to be beneficial. So we really take it seriously that we participate in clinical trials that are using proven therapies for patients. What about antibodies? I get this question a lot. Or what about antibodies? So there's been a lot of concern about if you're infected with COVID and you make antibodies, what does that mean? And I have this slide here to point out to people as we think through that. There are a lot of things we don't know about what that means. So the immune system is made up of a number of parts, and one of those parts is antibodies. There are also T cells and B cells and complement level and natural killer cells and all these different parts of the immune system. But antibodies are important, but probably not necessarily the most important thing. So when people say, well, I've had COVID, I want my antibody checked, we do that some. And they say, well, I have an antibody. Am I now protected? Do I really have to keep wearing a mask? What does this really mean? The answer is we don't really know yet. So we don't know how protective antibodies are. We don't know if we're measuring the right ones. We don't understand all the time why some people make them and some people don't, although most people do make them after infection. We don't know if you're more severely ill, you tend to make more antibodies than someone that has a mild case. It's not even clear what percentage of the population needs to have an antibody before we turn this around and get back to some semblance of normality. We don't know how antibodies cross-react with other more coronaviruses we've all been exposed to. So there are about 4 coronaviruses that, looking across the pictures on the screen, all of us are of a certain age. We would have been exposed to those and had general mild upper respiratory infections in the past. We don't know how those infections might cross-react with COVID antibodies. And we also don't know the role of T cells. There's been a lot of hand-wringing about, hey, we've noticed that antibodies go up and you have them for a while and they kind of fade down again. Does that mean you don't have any long-term protection? Well, not necessarily, because T cells may be part of the immune response to the virus even more than antibodies. So I show this slide because I typically get a lot of questions about antibodies. We do measure them. There are local studies going on now to measure what antibodies are occurring in the population and what percentage of people have them. But they're not a panacea or a solution to our problems as of yet. And what about vaccine? A lot of information about vaccine out there. So just know that we, as an organization, participate in the North Carolina Vaccine Advisory Team, and we collaborate with a lot of other healthcare systems in the state, as well as state and county officials. And we, as an organization, have 3 sites that have been approved for distribution of vaccine in the coming weeks when it's available. Know that the state of North Carolina has developed a prioritization framework that we speak into, and because there'll be limited vaccine when we start. And also know that as an organization and at the state level, we're committed to being inclusive and responsive to historical injustices in vaccine planning and medical care. So just like we have a diversity and inclusion lens on all the care we provide, we also have it around vaccine. This has got to be a fair and equitable distribution of vaccine. We have to, we know as vaccine is available, we're going to have to address vaccine hesitancy. There's a lot of that out there across a variety of groups. And some of those groups in our communities have very valid reasons to be cautious and suspicious of the medical establishment because of historical injustices. And others have hesitancy because of political reasons. So we're going to have to work through that. You may have heard this week that the Pfizer product, the initial quality or efficacy trial around Pfizer shows that it's potentially 90% effective. Now, we don't know exactly all the details on that because they haven't released their data, but we're excited to hear that. One of the challenges around the Pfizer vaccine product is it requires ultra cold storage, which is 70 degrees below 0 Celsius. So you can imagine the logistical issues around that. And we have purchased enough of those ultra low storage freezers that you can store, we can store as an organization about 144,000 doses. And so we're working with the state to help provide some of that storage in the distribution plan. There are a number of other vaccine candidates. I'll just touch on the Pfizer one for now, but I imagine that'll be the first vaccine available, and probably not available for mass distribution until sometime in the new year, but we may get some doses here at the end of the month or early December that would be prioritized for frontline healthcare workers and those living in long-term care facilities. So I want to move a little faster here because I want to give Daryl his time. I get a lot of questions about, hey, Dr. Priest, can I go do X? Can I do this activity? Can I do that activity? And I say, well, let's think about this. I love this slide. It came out from the Swiss Center for Occupational and Environmental Health. It really says, look, your risk of acquiring COVID is a joint probability. And it really involves these 6 steps. So when you think about whatever activity you're looking to do, what's going on there? Step 1, what's the strength of admission or emission? Are people yelling? Are they singing in a choir setting? What's the turbulence and the speed of air that's moving through the room? How much shared airspace is there? How much time are you going to be there? How many people are there? Are people masking? All of those things add up to a probability. The probability when you're around other people is not going to be 0. So then the question you ask yourself is, can I get on the good side of each of these things? Am I going to be doing something where people are yelling and maybe that's not the best place to be? I need to be somewhere where there's good airflow, big amount of airspace, fewer people, spread out, wearing a mask. Those are the safest things. And so you can imagine why the state government says restaurants and bars are problematic, because a bar, for instance, is on the wrong end of almost all these things. Very crowded, not a lot of air movement, people yelling and carrying on, not masked. All of that's going to raise your probability. So when you're trying to think through, particularly around the holidays, you can be very cautious and in family gatherings around Thanksgiving and Christmas and those kind of things. Think about this slide and think about how can I reduce my probability of getting COVID using these principles. So how do you protect yourself? This was a little illustration we did at Novan, but I point out several things around this. One is masking. Masking works. It works on a lot of levels. And even though there have been people who say, no, it doesn't work, don't do it. You're going to make your carbon dioxide go up. None of that's true. It works. So mask and do it very consistently. You've heard about social distancing, obviously. At its basic form, this is a virus spread among people. So if you're farther away from people, you're going to reduce your risk of getting it. I also point out avoiding conspiracy theories and false information. There's a lot of that on social media, and a lot of it, when at first glance seems like it makes sense, it often doesn't. So consider the source, understand what their motivation is, and say, hey, maybe I ought to check out the CDC website to see if that really jives with what this is telling me here. Know yourself. If you have chronic medical problems, your immune system has you have problems with your immune system, you're taking medications that influence how your immune system works, you're going to be at higher risk if you get COVID. So you may have to be more cautious and say, you know what, I'm going to watch that church service from home until there's a vaccine. Self-care. We're very aware of the mental health issues that have come along with this crisis. People need a break. We all do. And it's really an issue for healthcare workers who are 10 months into this without relief in sight, and watching the politics swirl around them has been very discouraging for healthcare workers. So make sure you take care of yourself in the middle of the pandemic, and those around you, get outside, get some fresh air, do some things that interest you, and take a break. And then I try to encourage patience and perspective. I think every generation has its challenges. And I think about my grandfathers and my great uncles who got on ships and headed to Europe and North Africa to fight the Nazis. And they made real sacrifices. And a lot of people have made real sacrifices around COVID, healthcare workers and those who've lost their businesses. But at its core, our sacrifice has often been wear a mask and stay socially distant, which to me doesn't compare to the sacrifice that my ancestors made fighting Nazis across the fields of Europe. So I try to think about that. And let's put this in perspective. We know we're tired of it. We want it to get better. There's been a lot of suffering, but this is our moment as a generation to step up and take care of each other. So I mentioned masks. I won't dwell on this for very long. Most masks work very well. The ones that tend not to work as well are ones that are knitted, bandanas, masks that have a valve in them because it may protect you but not the people around you, and then these neck gaiters. I'm not saying every neck gaiter, but this was a study that came out of Duke that suggested that those were not the most effective. In fact, it may have been worse because they made the droplets smaller. So what's encouraging about this study, Fisher et al. At Duke, is that most of the masks they tested were effective. And that gave me encouragement because I see people wearing all kinds of masks everywhere we go. Again, masks are effective and they work. Avoid bandanas and gaiters. I think you'll be in good shape. And then finally, children's schools. I don't want to take Daryl's thunder, but remember that children are important drivers of respiratory viruses and influenza every year in a community. And they tend to have milder cases of COVID, but they still can have serious complications, and they can be asymptomatic spreaders. So the data on infectiousness in children is actually pretty mixed, and we can learn some things from other parts of the world. So for instance, in Israel, when they went full bore opening the schools again, their cases went up. So we know that if we're not using caution, and I think the school system is using caution and has done a nice job, we have to be cautious about even masking kids, spreading them out, working on ventilation in the schools, because we do know that kids drive respiratory illness in communities. So we're hopeful that taking the right steps, we can avoid this. You have to be careful if COVID is exploding in a community, you have to be careful about school system opening. But my vote would be we prioritize school system opening over restaurants and bars at this stage, particularly as we enter flu season. And speak of the devil, and this is, I think, my last slide, the influenza, if everybody, I think sometimes maybe influenza gets a little jealous of the attention SARS-CoV-2 gets, but let's not forget in 1918, there were 500 million cases worldwide of flu that year and 50 million deaths. And every year there are thousands of cases, lots of hospitalizations, and a lot of deaths. So the question is, what's going to happen as we go into flu season now? The good news is in the Southern Hemisphere, they've had a very mild flu season, which comes before ours, because the same things that protect you against COVID protect you against the flu. So if we continue to be socially distant and mask and wash our hands and stay home when we're sick, then you're going to see influenza not be as big a player as it often is each year. So I can tell you, we've had very few flu cases. In our 15 hospitals, we've had one. In our ambulatory sites, we've had maybe about 20 across 600 sites so far. Now that could change because flu season often comes in February at its peak, but just know that this is a concern of ours, and the importance of flu vaccination and doing all the things we're doing around COVID will hopefully keep the flu rates down where they need to be. And with that, I have this slide. I love this cartoon. It's actually back from March, and it just speaks to who I consider the heroes, some of the heroes, of course, the ones in the world I live in. There are a lot of heroes, including teachers who have been heroes and essential workers in this as well. So I'll stop there. And Sylvia, I'll turn it back to you if you want to do questions, or you want Daryl to go ahead. I'll go from there.
Okay. Dean, what do you think? Have a couple of questions for us as we move into that time?
Let's take a few questions that have come up. I think one of the most important was the last one I saw posted, which is, given the news we're getting about vaccines and the questions people have about how quickly we've tried to work on vaccines, would you be yourself willing to take this first vaccine that comes out that seems to demonstrate so much promise?
Yeah, it's a good question. I have this vision that I'm going to be on our intranet at Novant Health, getting the vaccine for everyone to see. I want to see the safety data, right? So the only thing we know right now is 90% effective. So we want to see all the safety data and all that kind of stuff, because it has to be safe and effective. I will say, I think the companies involved in this, Johnson & Johnson and Pfizer and Moderna and others, they understand the public hesitancy about this for often, like I said, very legit reasons. There's been also so much misinformation, purposeful misinformation from anti-vaxxers and those kind of crowds. They realize they've got to prove it's safe before they give it to people. So their clinical trials have been quite large. 40 to 60,000 people have been involved. And so that's encouraging to me. There's no vaccine that doesn't occasionally have a side effect, though. I mean, any of you have got a Tdap, know your arm can hurt for 3 days or give you a little fever. And so I worry a little bit about that. If someone will have a mild reaction, and they'll be on Facebook the next day putting that in there and trashing the vaccine. So remember, most of these are going to require 2 doses too. So I think there's not going to be one for everybody to begin with anyway. We'll continue to get safety and quality data, but absolutely, if they say, look, this is the safety profile we saw, we think it's this effective, this is the way the vaccine was made, then I would certainly be willing to get it.
Okay, we had a few other questions that have to do, I think, with some of the local figures. One of them is knowing that health providers are at risk of contracting the virus. Have we had much in the way of an outbreak among our health providers here? Secondly, are you continuing to see the higher rates among the Hispanic community, and how does that relate to mortality or severe cases? And then finally, you mentioned distribution centers, 3, I think, and I just wondered if those were local or scattered across your footprint.
Sure. So we have seen a number of cases in healthcare workers. Most of the time, we don't believe those are acquired from patients, because our healthcare workers have the personal protective equipment they need. We do know that sometimes we've had to talk to our healthcare teams about the break room, right? So you're working very hard with patients, you go in the break room to have lunch, people take off their masks, and we've had healthcare workers spread among each other or out in the community. So we've had very few, if any, that I feel like, hey, that person got it from a patient, although sometimes it's hard to know that. We have had 1 death in our system among a healthcare worker. That's public knowledge and has been out there, and that's certainly tragic. We at any one given time have 100 plus. We have 30,000 team members, so we'll have 100 plus who've been tested or out with COVID. Any given time, we generally have about 8 team members who are hospitalized, and sometimes 3 or 4 in ICUs across our system. So yes, healthcare workers are right there on the front lines. In terms of our Hispanic populations, yes, it has been disproportionately affecting those communities, and often it touches on healthcare disparities. So we've had times in the pandemic where we've been testing, say our testing center in Waughtown Street, and people that come there may be Hispanic, and 30 or 40% of the tests we do are positive. And then we test everybody having an elective surgery, and 0.4% are positive. So what's the difference? Well, if you're having an elective surgery, you may be more likely to have insurance. You may be more likely to have a job that lets you work from home on your computer with your dog at your feet. You may be able to afford having that knee replacement. You're not going to get COVID. There's a healthcare disparity there. On Waughtown Street, you may have to go to a job where you have to be in person, maybe at the local chicken processing plant. Maybe you live in a home with more individuals there. Maybe you don't have the resources to have the same kind of health insurance, so your risk is higher. So what's really revealed is healthcare disparities between different, not just this Hispanic community, but different parts of our community overall. So that's really drawn our attention to those healthcare disparities. The mortality rates have been lower in our Hispanic population. They tend to be younger when they get admitted, but we have seen some deaths. And then in terms of our distribution centers, we've been approved at Forsyth Medical Center, Presbyterian Medical Center in Charlotte, and Brunswick Medical Center down on the coast. So we're trying to get a geographic spread. This initial wave of vaccine, I don't think is going to be a situation where you go to your local doctor and get it, not for the Pfizer product, because they don't have those kind of freezers. Other products may allow it to be put into a local doctor's office. I think it'll be more in specific vaccine centers to start with.
Okay, I'm going to interrupt. We have a couple of other important questions that I'm going to hold and come back to later, but we want to be sure we give Daryl Walker time to tell us about what's actually happening with the schools. So Daryl, you're on.
Thank you. Thank you, Sylvia, for driving for me. This is a pretty extensive plan that has been in place and we've been working on since actually started on March 13th. We actually met on that next Saturday, that next day, the 14th on Saturday, and started a planning process. So a lot goes into this plan, and we'll try to run through it pretty quickly. These are kind of key components that we talk about every time we meet, and we do meet almost every other day on some type of planning activity around going back to school or preparing to go back to school, and that is around our facility readiness, you know, what those budgetary needs are. CARES dollars has helped support some of those. How do we prevent as much community spread as possible when we go back to school and do that safely? And again, that safe return plan is well thought out and planned. We created a vision and mission around our work just to kind of keep us centered. And also that part of our mission was to, is we're utilizing guidelines and mandates outlined by the governor, NCDPI, which is Department of Public Instruction, our NCDHHS and CDC. Will be interesting today. Our governor is going to speak at 3 o'clock today. So we will be eagerly awaiting to see what that looks like as part of our plan moving forward. Our objectives around public health are obviously to keep our students and our community at large as safe as we possibly can during this pandemic, where there is no vaccine, which we know there is. This was a little bit dated. And public education wise is to provide all of our students with equitable educational opportunities. That you may read a lot about or heard a lot about our CARES teams going out and supporting our students, trying to keep kids focused and during this time so that we don't lose kids along the way. And so our goal is to keep everyone involved, ensure that we continue to be responsible and productive global citizens during this health crisis. Our goals are safety and well-being of our students and our employees, equitable accessibility for all of our students during this really challenging time, instructional delivery to meet the needs of all of our students, and positive relationships and interactions for students and teachers, whether it's in person or virtually. So there's a lot of work, as I mentioned, going into the safe return plan around our district-wide planning teams. There are school-level planning teams. We'll have a lot of discussion and planning around our building cleanliness, our healthcare professionals, the manage the isolation of students who become ill throughout the day. We've created some great working relationship with the health department, as well as we have more nurses within our schools right now. Fortunately, we've created some isolation rooms that are being supported by those folks, as well as school staff and staff and teachers in the building, setting examples. Had a lot of training take place about wearing masks and social distancing that we hear so much about. And we've spent some time looking at best practices of other school districts, as I've spent about a week out and about across the state of North Carolina looking at what those opportunities are. Transparency and reporting of positive cases in our school system obviously has been very important as we continue to move forward. And we have a dashboard now that is posted out there on our website, targeted educational information campaign about our safe return is exclusive of parent information sessions. We've had some town hall meetings. And then a lot of information on that our safe return page that's on our website. And as we were talking a little bit earlier, all of us have gotten to know Britt Campbell very well, as he calls you almost daily, try to keep you updated amongst our students and our staff and our parents. Staff identified a follow-up person who fails the building entry screening process. We have teams, contact tracing teams in place now as we begin this transition. So let's talk a little bit about transition to Plan B for our students. We have a few options that for our students. 100% virtual academy with synchronous instruction has been in place early on. That got put together in a really short period of time to give, knowing that we were going to probably open up in Plan C. All of our kids were virtual. We now have an in-person by cohort combined with remote learning. We've got some new technology around that to allow us to be able to have kids in the classroom and kids remotely hearing the same lesson so that teachers don't have to make that presentation on 2 different occasions. And then again, we have remote learning from homeschool, which may include synchronous or learning packets, videos, recorded lessons. And then our high schools will offer in-person and synchronous after the first of the year. Our social distance capacity is really around having fewer students in the building to minimize overcrowding in those areas of pickup, drop off, and our buses, hallways, entries, stairwells, those common areas within all of our buildings. Therefore, we've kind of proposed dividing our students into groups of 2 or 4 cohorts to increase the social distancing piece and lower the capacity within the building. Depending on the size of the school, will determine whether they are a 2 or a 4 cohort school. So let's talk a little bit about employees in this transition. This chart shows you teachers. All of our teachers are back except our high school teachers. They will return, if you'll see the very bottom left, November 30th. You say, well, why they're coming back on November 30th if we're not going back to school in January? A lot of that is to kind of support the administration of the school, do some training, get acclimated to the new technology, policies and procedures around our check-in system that they have to do on a daily basis. And so, we will have a 2 or 3 week break in there with Christmas. So we wanted to bring them back and give them a chance to get acclimated. But all of our other teachers are back as of Monday, as you can see there. And our board will talk a little bit about make a decision. We have first graders coming back. Kindergarten EC came back last Monday. Our first graders will come back this following Monday next week. And then our board will talk on November 17th and make a decision about those remaining grades 2 through 8, as you see there on the chart. And part of this process is really to create a good, vast array of employee support to make sure that our employees really felt that we were really doing all we can to protect them. So we've asked kind of set up some processes around that. And we have an employee assistant program that's available for those for mental or emotional support during this time. We have seen a big uptick in that, quite honestly, since since March, and the need of support for mental health support for our teachers, staff, as well as students. More about employee support with a medical condition that prevents them from returning to work. They are to contact our HR to request accommodations. We do have quite a few of those that we are working with at this time as teachers begin to come back onto campuses. Obviously, that creates a lot of questions around subs and where do we have enough to support going back to school. That will continue to be a challenge for us and thing that we talk about and look at almost daily. They also may be eligible for leave under the Family First Coronavirus Act that extended their up to 80 hours of paid sick leave. You can see those features there: family medical leave expansion act up to 12 weeks. But this does expire right now, scheduled for December 31st, 2020. And then we've asked our employees to contact HR if they needed extended leave options. Let's talk about a school day in Plan B and kind of what that looks like. When you enter the school bus, the driver will has been provided PPE with a mask, a shield, face shield, gloves. We do have some limitations of what we can put on the bus because the state of North Carolina Department of Public Instruction dictates a lot of that. We are only allowed one student per seat unless there's a sibling. And so a 77 passenger bus, we'll only be able to transport 24 students. So it's going to be a really challenging year as it relates to transportation as long as we continue in this mode of operation, and/or we'll see a lot of big increase and uptick of car traffic around our schools if we were to come back with the rest of our grade levels. Temperature checks will take place this at the car riders before they get out of the car. And then the essential questions will be asked of each student. We'll also be checking temperatures when kids get off the bus each day and not before they get on the bus. That's it's kind of been a really hot topic around with our discussions with our bus drivers. I met with them Friday night for a couple hours talking about that process. We will check them when they get on the bus, but they'll be checked again and ask the essential questions when they get off. A lot of signage within all of our buildings. This is just an example of what you'll see in multiple languages throughout all of our schools. Let's talk a little bit about child nutrition. Right now, most of our schools, our students will be eating in the classroom. They will be getting up, going to the cafeteria in most cases to get their food and then transition back to the classroom. That creates another whole logistics issue to deal with in a lot of different ways. But we wanted to make sure that our kids stayed in their cohorts. You see the social distancing 6 feet apart. The signage of these floor labels are in every school within the district. And so you'll see them everywhere in the common area and restrooms as you walk through your schools. You'll also see hand sanitizer equipment, again, in all the schools that were provided. Every school's got multiple units of these, plenty enough to be able to serve our student population as well as our staff. Social distancing in the classroom, all classrooms are set up where a desk are at least 6 feet apart. And so your capacity of your classrooms that may have 27, 28, 25 kids in it are now somewhere between 15 and 18 for the most part. Some of our smaller, there may be smaller classrooms, but the average is around 15 at this point in time. Our playgrounds are open, but we're continuing to monitor that and asking our children to be, as much as we can, social distancing, wear their mask when they're on the playgrounds and outside as well. A lot of resources that are available. Our Safe Return link on the school website, as I mentioned earlier, has a lot of information on it, a ton of information. As well as some parent and student frequently asked questions, a lot of the latest updates. The toolkit was updated yesterday from DHHS. We're making those changes to get them on there as well. We also have a hotline as part of our bully patrol and a COVID risk tip line, that you call in if you have maybe somebody's not wearing their mask properly. We've had a few calls on that, and so we've opened that line up just within the last couple of weeks. Try to run through it pretty quickly, give some time for some questions, and I really appreciate the opportunity to be here, talk a little bit about it. I know I ran through that pretty quickly. I do really quickly want to just say, on the building side, we are installing in our schools. We started the process on our mechanical systems called bipolar ionization, and it basically cleans and purifies the air as it enters the classroom. It's attached to our energy recovery units that are on top of our building, or our individual units that feed our classrooms. That cost about $30,000 per school to install this technology, but we have begun that process. We've got about 14 schools completed. I am going to our county commissioners on Thursday to ask for some additional funding to complete that task, which is around $2 million. But I feel pretty confident we'll be able to continue that work. And then right now, and I think what will also help us, as Dr. Priest mentioned about the flu season, I'm really interested in tracking this to see if it helps on our attendance as we go through flu season, as well as allergy season that comes up in the spring. So we did mentioned earlier, we did have our EC and our pre-K kids come back last week. We're averaging about 9 or 10 kids per classroom right now. Kids seem to be really happy to come back. It was really interesting to be outside of a school when you're dropping off your pre-K kid. There were a lot of tears shed within the car. We didn't allow them to come into the building, and anticipate. I saw a little bit of that again on Monday with our kindergarten kids. Sure, there may even be some with our first graders as they come next week. But we appreciate the work that's taken place with our staff at our schools. Have really been dedicated to this task and trying to move forward in the safest way that we possibly can. And again, our board will talk a little bit more about those 2nd through 8th graders on the next Tuesday, the 17th. And with that, I'll be quiet and let you answer any questions you may have.
Thank you so much, Mr. Walker. And I've been quickly trying to write down some of the questions that are coming in. One of the questions had to do with whether there was community input into your planning process for the safe return. For example, did you hear from the Forsyth Association of Educators? Did you hear from Action for Equity or other grassroots organizations?
We did, and I think I saw Val on the call here today, and she was very supportive in giving us feedback of their thoughts as we tried to return safely. This is very emotional time for a lot of people, and really scary times, because you just didn't know what to expect when you brought kids and adults back. But we did have some input from our community as part of our planning team, as well as some conversation with FCAE and SAE.
Okay, a couple of other questions. When you talked about reducing class size from, say, 27 to 15 or 16, how did you manage that? How were you able to spread those students out? Did you have to hire additional teachers? How did you manage that?
Well, so it's kind of in a cohort. So the biggest challenge was moving furniture, to be honest with you, storing additional furniture. And you had a classroom with 25, 26 desks in it. We either marked off some of those or we had to remove furniture. That scenario, you would have 15 kids in a classroom. Some of those chose to stay virtual, and that really kind of prevented us from having to hire a lot of additional teachers. We do have about 3,000 students in the virtual academy who plan not to return to school, at least at this point. And so we didn't, the virtual option kind of helped and assisted in that scenario.
Another question specifically for you, and then a couple that might be answered by both you and Dr. Priest. One question was, how did you prioritize which schools would get this expensive ventilation equipment first? You said you've done 14 schools, I think it was.
Yes, ma'am.
Where'd you start?
Yeah, that's a great question. So on a lot of our schools, we have what we call an energy recovery ventilation, which is that if you look on the top of a lot of our schools, you'll see this big metal box. And basically what that does is recirculates air and refreshes air. And it brings in outside air, cleans it, moves it back into the building. There are 11 schools that didn't necessarily have what we call outside air. It has air conditioning, it has heat, it's got all that, but it didn't have that conditioning piece. So we started with those schools first.
Okay.
Those 11 schools, and most of those were older schools. You may recall we did a HVAC renovation at Ashley Elementary a couple years ago. We actually put the bipolar ionization on Ashley when we did that school a couple years ago. I will tell you, when we finish this, we will be probably the only school district in the state of North Carolina that I can find that has gone through this process. But I'm convinced the technology, I can tell a difference when I'm in the space. Feels a little crisper, cooler, takes a lot of humidity out of the air. So, yeah, we decided that based upon those outdoor air units.
Okay, so questions maybe for both of you. A question was raised about whether the plastic shields are more effective, less effective, just as effective as other masks.
Yeah, this is David. So the answer is no. Masks are still best. Now, the whole idea around eye protection is that you can get the virus into your mucous membranes in your eyes. So it's not that the shields have no value at all, but the problem with the shield is that open space underneath. So if I know some people who have trouble wearing masks have gone to a shield, I think it's probably a little better than nothing. But if you truly want to be protected, wearing a mask with the shield is preferred.
A couple of the questions that probably are more for you, Dr. Priest, that we had left on the table earlier. One is, as you factor into your marketing and reaching out to people about the safety of vaccines, have you factored into your planning and thinking the hesitancy that the African-American community may feel because of things like the Tuskegee experiments earlier, or other kinds of things that were discriminatory in the past?
Yeah, absolutely. And that's part of the state discussion as well. And that is definitely a part of the conversation. And ensuring that we have members of the African-American community, or all communities, who are members of those community who can speak to the safety and quality of a vaccine. It's really interesting. I think it was WRAL did a survey a few weeks ago, maybe even 5 or 6 weeks ago now, that looked at vaccine hesitancy. And that was certainly a part of it in the African-American community, but you also had 23% of folks said that they would never get a COVID vaccine, and those tended to be rural, white, male conservatives. And so, to your point, there are a variety of reasons there's vaccine hesitancy, from Tuskegee and the terrible things that went on with that, and historical injustices related to that, and racial disparities in healthcare, to modern political things. So we have our work cut out for us, and we're hoping that a change in message from the top, some consistency in national messaging, will help get everybody on the same page. But it'd be very important to engage those communities, engage members of those communities with experts who are from those communities and look like the people in those communities.
Okay, a question, Mr. Walker, that's probably more for you. The newspaper this morning pointed out that there have been a number of cases, both in terms of students and faculty. So could you speak briefly to the plans for how you respond as there are cases when children are returning to school?
Well, yeah, we did have an outbreak of 6 staff members and 1 student at Moore Elementary. A couple weeks ago, we had closed that school last week. We are back open now. We went through the protocols and cleaning processes through that. I think that came from someone from outside event to a staff meeting that was held. That's kind of how that got passed along and more. But we do have contact tracers in place, as well as a group of nurses that we have contracted with now that are supporting our contact tracing process in our schools and our families as we can, continue to go through this.
And Dr. Priest, someone asked a question about whether there's any efficacy in vitamin D or other kinds of natural supplements.
Yeah, so that's a really good question. There is some preliminary thought that individuals with vitamin D deficiency may be more likely to acquire COVID and have complications from it. So the advice has been, if you have vitamin D deficiency, yes, you should supplement that. If you don't, we don't know there's a lot of evidence that you should take vitamin D. There's a lot of these protocols that float around, even from doctors that say, if you get COVID, take zinc and vitamin C and vitamin D and this and that and turn around 3 times. And there's almost no data to support most of that, except if you are known to have vitamin D deficiency, it's worth taking. I also think it's worth taking an aspirin if you get COVID. There are a lot of complications related to COVID in the cardiovascular system. And clotting is one of those. So these other unproven therapies, I don't put much weight into. The other thing that's just been approved is a monoclonal antibody infusion for outpatients. That's a challenge though, to figure out who to give it to and how to give it to them, because it requires an infusion into someone who has COVID, and where do you do that? So all the healthcare systems in the state are having that discussion now, but it was an Eli Lilly product that got emergency use authorization this week that may be a potential outpatient therapy in addition to all the things that people throw out there.
And Mr. Walker, this may be a question that's kind of more in Brent Campbell's bailiwick, but I will ask it and see if you can give us any information. There's been concern expressed about the children, maybe 600 or more, that you've not been able to reach. They haven't shown up. They haven't registered in anything. Do you know where that number stands now in terms of kids that sort of have gotten lost in the process between the 2 years?
I don't have that exact number. I tell you, I did have an email this morning. I haven't had a chance to kind of review that. Let me, if you don't mind, I'll share that with Sylvia, and she can share it out with the group. I do know that our CARES teams have been very busy out working, knocking on doors. There were some kids that we have not been able to kind of find, and I don't know where they have moved out of the community as we started this process. Our right now, our student enrollment that's in is probably down about 1,200 students from this time last year.
One more question, and then we'll be closing out for the day, and I'll turn it back to Sylvia. And Daryl, you've mentioned the school bus, the attempts to keep school bus transportation safe. There have been a number of remote learning centers established, and some of those plan to continue offering after school tutorial assistance to those students that are struggling. But I think, if I understand, that the buses will not transport kids to these locations. Is that correct? Will they only go straight back to their neighborhoods?
That is correct. Right now, because of the limited capacity, we're only transporting residential students to their residential schools that they attend. There are no choice, no magnet. We are trying to help support families though. There's a lot of kids who get dropped off at daycares. I think I saw Imprints on the call. They've been a great partner of ours. as well. And we're just trying to find any way we can to support those students, as well as our students that are in foster care and our homeless students. We have about almost 1,000 kids that are considered homeless that we have to find a way to transport. And they may go to school here, but live in, I've got one that we're transporting from Concord, and then, most of them live in Guilford or in Davidson. So our transportation system is really kind of stretched thin. And because of the social distancing piece and being only allowed one per seat, are really limited on what we can provide.
Sylvia, I know we're out of time, but I just saw a question that in terms of equity deserves being at least put on the table. And that is, and I don't even know exactly how to phrase it, parents are making decisions as best they can for their own children and students, but how can they make those decisions thinking about the whole community? Since school buses, for example, are only transporting you to your residential school, do you have any advice for parents who are trying to think not only about how their own student can best be protected, but how they should make their decisions in light of the whole community? Any comments, any thoughts?
Great question. One we kind of tossed and turned about. We've just been trying to find any way we can to better support our students, even if we have kids that can congregate in places, churches and places like that. We can pick up large groups of kids, possibly with activity buses as well. We're just trying to broaden our horizons to be able to give everybody a fair shot at this. It does create a lot of concern on the equity issue, quite honestly, especially when it comes to choice. And so I'm not sure I have an answer that everybody would be happy with, but I can tell you it is on the forefront of everything we discuss.
Sylvia, back to you if you'd like to close us out.
I will. Thank you, Dean, for helping to moderate the Q&A, and thank you to both of our presenters today for some very, very helpful information. I know I took in a lot of notes, and I know that many of you did as well. And that's also a good segue to just a tease for our topic next month. We will be looking at that kind of question about what churches, what community groups can do, because your point about equity and being concerned and helping others besides just our own children is very important. So we'll be focusing on one or two really key remote learning centers that have learned some lessons and how that can be transformed into broader activities on everyone's part. And I think the fundamental question is, how can we take these lessons and these experiences, as tough as they are for all of us, and translate that into a more just and equitable education system. So thank you for being here. David Priest and Daryl Walker, we learned a lot from both of you. We do have our Facebook group page that I mentioned. However, still have a few more steps with our social media experts to kind of get that up and running. So we'll send you a link to that in the email. Faith in the City email. If you are not on our email list and would like to be on our list, please put your name in the chat and we'll add you to that list and make sure that you get invited. This is where we can share a recording from today's session, as well as I'm sure our presenters would not mind their PowerPoints as well being shared and some of the links that they had. Any further comments from either one of you before we leave? Thank you again. And thank those of you who were on this session. Very, very helpful. Thank you for being part of Faith in the City. Have a good day.
Thank you.
Mm-hmm.